Hello, I'm Kathleen Brady from the Medical University of South Carolina. And with me today, I have Dr. Sandra Springer from Yale University.
Hi, Kathleen.
And Dr. Alain Litwin from the University of South Carolina in Greenville.
Great to be here, Kathleen.
Thank you both. This is the CME accreditation statement for today's activity. I'd like to review the learning objectives. Number 1, implement the most recent screening, diagnostic, and treatment guidelines for HCV or HIV. Number 2, identify barriers for initiating pre-exposure prophylaxis to prevent HIV in people who inject drugs, and discuss interventions that could prevent HIV transmission. And number 3, evaluate barriers to direct-acting antiviral treatment initiation in patients who are suspected of injection drug use. These are the faculty disclosures. This activity is supported by an educational grant from Gilead Sciences. All of the activity, content, and materials have been developed by the activity directors and planning committee. Let's begin with a case presentation. Mario is a college student who was injured in an all-terrain vehicle accident. He sustained 3 fractured ribs and an open leg fracture. These were surgically repaired. He was previously healthy, had no chronic health conditions. Mario was prescribed opioids while recovering from his accident and surgery. However, after 6 months, his primary care doctor discontinued the opioid prescriptions when Mario requested early refills. In addition, Mario admitted using benzodiazepines that had been prescribed for his girlfriend. What is the role of substance use disorders in the treatment of HIV and HCV? Well, we know that current alcohol abuse and drug use are associated with poorer outcomes and incomplete HIV or HCV treatment. That ongoing drug and alcohol use is associated with poor adherence to ART and inability to maintain HIV viral suppression. So integrated treatment, treating both the infectious disease and the substance use disorder at the same time in an integrated fashion, is really the optimal treatment to improve outcomes. Medication treatments for opioid use disorders, which we'll explain later on in the presentation, is really the best studied intervention and has been shown to be associated with both improved HIV suppression and with HCV cure. The opioid crisis is something that no one cannot have known about at this point. And I just want to explain a little bit about this slide right here. Shows us the 3 waves of the opioid crisis. You know, in the 80s and certainly 90s and early 2000s, there was an increase, you see that purple line, in opioid prescriptions by doctors. And this is primarily related to poor education about the use of opioids, poor education about alternative strategies for management of pain, and aggressive marketing by drug companies. And so as prescriptions increased, so did opioid overdose increase. This trend became much more broadly known, and many doctors began to more abruptly stop people from opioids because there was such concern about opioid prescribing. And you can see there was a bump in heroin overdose deaths. So one of the things that we know is many people who were taking prescription opioids either couldn't get enough from their doctors, were cut off abruptly, and heroin use went up and heroin overdose deaths. That's the yellow line. Finally, around 2014 and 15, there began a trend for other synthetic opioids to really overtake the use of prescription drugs and heroin in terms of abuse and overdose. Many of these drugs, fentanyl, carfentanil, are 10 to 100 times more potent than prescription opioids. They have a much lower therapeutic index and they're much more lethal in terms of overdose. And you can see around 2014 that it really is the synthetic opioids that have taken over as the major culprits in terms of overdose death in the United States. At this point, I'd like to turn things over to Dr. Springer to discuss the interface between injection drug use and HIV.
Thank you, Kathleen. We've also been seeing alarming rates of other infectious diseases associated with the opiate epidemic. In particular, globally, we know that injection drug use is responsible for roughly around 6 to 8% of HIV transmission rates. And right now we're seeing among new HIV cases, a majority of those new cases occurring in younger populations, roughly in the 20 to 24 age group. Other trends that we're seeing demographically in people who are injecting drugs and using drugs associated with the opiate epidemic in this country are individuals who are more likely to be younger, female, and existing in rural populations within this country. Just to demonstrate something of which, unfortunately, we saw with the prescription opiate epidemic in this country in Austin, Indiana, was a new HIV outbreak, as well as a hepatitis C outbreak in people who were injecting drugs. In particular, it was oxymorphone, a prescription opiate. And this was in a state that roughly had around 10 to 14 cases of HIV per year, but by mid-April had roughly 130 cases, and then by November, over 181 new cases of HIV. And this paper demonstrated that they were able to match and follow where these patients acquired HIV, and it was directly related in the majority of them to injecting and sharing injection drug use materials of this prescription opiate, oxymorphone. That was in 2015. Since that time, we've seen now over a half a dozen new HIV epidemics occurring in this country related to those who are injecting drugs.
Let's talk about screening for substance use, HCV, and HIV. In terms of screening for substance use disorders, it's better if you embed these questions in just sort of the general questions you have about people's psychosocial environment and behaviors. There's really two basic approaches. You can either use a single screening questionnaire that some of these are very brief. They've actually been validated in primary care. And the virtue of these is that they're easy to memorize and you can fit them right into the flow of your interview much more readily. The other approach you can take is more standardized questionnaires. These can be a little bit more difficult to administer and score. However, they do provide more information about severity and consequences, so they do have their added value in that way. In terms of the single screening questionnaires, these are brief, as I said, have already been validated in primary care settings. For drug use, we've got 93% sensitivity and 94% specificity. The drug use question is, how many times in the past year have you used an illegal drug or used a prescription drug for non-medical reasons? If you're asked to clarify the meaning of non-medical reasons, the interviewer usually can add something like it's used because of the experience or feeling it caused, not necessarily used as prescribed. Standardized screening tools have advantages of giving you more information. They can be computerized with automatic scoring, and so often they can be included in the EHR, automatically scored, and the physician or practitioner can be prompted if there's a high score to address that. You know, in terms of screening, there's so much comorbidity between opioid use disorder, HCV, HIV. It's pretty clear that what really should be the standard is in all primary care and infectious disease clinics, there's screening for substance use disorders. And in substance use disorder treatment places, we should always be screening for infectious disease.
In terms of screening, it is recommended by the CDC since 2006 for all individuals between the ages of 13 to 64 to have at least one HIV test. And we call this opt-out screening now, where patients should be told screening will be performed, but they may decline testing, but you don't have to ask for official consent and provide prevention counseling before you do the testing. It's recommended annual HIV screening for those at high risk for HIV. However, it should be done every 3 months if someone is negative, if they're continuing to partake in high-risk behaviors such as injection drug use or having unprotected sex with unknown status or HIV positive status partners. So the standard laboratory testing is just a one blood test. It's a HIV P24 antigen antibody combination test. Typically, you can follow up or have the person return to the office within the next 7 days for a positive test. I would also like to recommend, however, that to consider HIV rapid tests, which can give you a test result within 10 to 20 minutes after performing the test, either through an oral swab or a finger stick. These point-of-care testing are recommended by the World Health Organization and used in multiple different settings. And now I will turn this over to Dr. Litwin to talk about hepatitis C testing.
Thank you, Sandy. So I definitely recommend looking at the AASLD and IDSA guidelines, hepatitis C clinical guidelines that are updated continuously. One-time hepatitis C testing is recommended for persons born in the baby boomer birth cohort, so those born between the years 1945 and 1965. And then we can divide it up into people that have risk behaviors and either exposures or being part of groups that may have higher prevalence. And so those risk behaviors include injection drug use, even if you inject it only once, as well as intranasal or snorting drugs. And then the exposures, some of them that might happen through healthcare if you're chronically on hemodialysis, if you received a blood transfusion before 1992, or clotting factors before 1987. If your mother had hepatitis C and you may have acquired it during childbirth. And then some of the groups that really are related to some risk behaviors in the past would include if you've been incarcerated, as well as if you're an injection drug user, which we talked about. And then finally, with the recommendation of how often should we test, annual testing is recommended for two groups, for people who inject drugs, as well as HIV-infected men who have unprotected sex with men. And in fact, for these folks who have ongoing risk factors may decide to test more frequently. One other caveat is that there's a number of reports that show the cost effectiveness of universal hepatitis C screening for all adults 18 and over that have emerged. And this is really because we've had a shift from the baby boomer epidemiology of that being the most prevalent group affected by hepatitis C to now we've heard all the young people under the age of 30 who are getting, if there's really a bimodal distribution. So just as we put forth the birth cohort, really we're seeing this new phenomenon. So it really makes sense to do the universal testing. That's not yet recommended either by CDC or the United States Preventive Task Force, but we are hopeful that those recommendations may be forthcoming. So the first step is to get an antibody test. And if it's negative, then in general you don't have hepatitis C. Now, it's really important to understand it's a two-step process. So you have the antibody, but then you want to get the viral load as well. And it really should be, if you're doing it in a lab setting, have it reflex. So you don't have to have a two-step separate, kind of bring the person back, but it automatically will be reflexed over to a viral load test. Now, if you're out in the field in a syringe service program or other settings, you can also use a point-of-care test, which is a finger stick test. It takes 20 minutes, and then if it's positive, ideally then you'd want to then draw a follow-up viral load test, again to minimize the multiple steps that are needed to get someone into care, because at each of those steps people could be lost to follow-up. And finally, once you've confirmed that diagnosis with an antibody and a viral load that are both positive, then you must evaluate and treat, ideally with a co-located model of care, but also important to refer if you don't have the ability to treat where you've actually diagnosed your patient.
We're going to continue now with the case of Mario. Mario is the gentleman who had the accident, was put on opioids for 6 months, and then was asking for early refills. So at that point, his physician used the screening tools we've just been talking about. What he found was that Mario was positive for opioid use disorder, but fortunately for Mario, had none of these infectious diseases. So what are the next steps? As we mentioned earlier, Medications are really the state of art and the recommended treatment for individuals with opioid use disorder. So anyone with an opioid use disorder should be offered medication treatment. And we have three basic classes of treatments that we use for opioid use disorder. The first are full agonist therapy. Methadone is the main drug in that class. Methadone is a drug that's used orally, once daily administration. It's been available since the 50s. It has to be administered within a licensed facility, so it's a very highly structured administration where individuals come in almost every day. After they've been coming in daily for some period of time, they can begin to get take-home doses. But one of the reasons it needs to be administered in such a highly structured setting is that the potential for overdose with this full agonist therapy is actually quite high. Buprenorphine is the next class of drugs, a partial agonist and a partial antagonist. It's available in several different formulations. You can take it sublingually. You can administer it via film, which is applied to the skin. You can administer it via an implant, which is then 6 months worth of dosing, or injections, which are given every month. The nice thing about buprenorphine is it can be given in a primary care setting or a buprenorphine clinic, which with less structure than is required around methadone maintenance. MDs, in order to prescribe buprenorphine, need an 8-hour waiver training, and nurse practitioners are now allowed, as of the last year or so, to prescribe buprenorphine, but they need a 24-hour training to attain their waivers. It has less interaction with the antiretrovirals. It reduces HIV risk behavior and reduces the potential for overdose. And it does improve viral suppression in HIV treatment. The final class of medications are the full mu antagonists, and these drugs sit on the opioid receptor and block other opioids, other agonist drugs from having their effect. So if someone's on naltrexone and they take a prescription opioid, they're likely to not feel the euphoric effects of their prescription opioid. It's available in 2 formulations. One is an oral formulation, which is given once daily, and the second is an injectable formulation, which is given monthly. Because of adherence and compliance concerns, really the monthly injectable form is what is recommended in the treatment of opioid dependence. Again, naltrexone can be administered in a primary care setting, in a buprenorphine or substance abuse treatment clinic setting. There is no special waiver or licensing required for naltrexone administration. The injectable formulation certainly has an adherence advantage because you only have to worry about once a month injection rather than daily people self-administering the drug. There are no concerns with overdose or diversion. It really doesn't have any abuse potential in and of itself. Again, reduces HIV risk behavior, reduces the risk of overdose, and improves viral suppression in HIV treatment. Next, I'd like to turn it over to Sandy to talk about HIV prevention.
Thank you, Kathleen. So we now are at this point where we have tested an individual, and hopefully individuals are being offered HIV testing and substance use treatment programs. At the time when they offer the HIV test, and if it comes back negative, they should be then offered potential HIV prevention treatments. So it's important to ask when you do your HIV testing if they've had any high-risk behaviors within that last 7 to 14 days when you're doing the test, and if they're having any symptoms or signs of acute retroviral syndrome related to HIV, which include fever and flu-like symptoms. If they have or acknowledge those symptoms or have partaken in high-risk behaviors, that you should, in addition to the HIV antibody test that I'd recommended before, also do a HIV viral load as well. And with that caveat, if all of those tests are negative, And it is very important to offer or at least refer to someone who can provide HIV prevention treatment. This term is called PrEP. You may have heard of it, pre-exposure prophylaxis. It's recommended for all individuals who have had any unprotected sexual intercourse with men or women, or who have been injecting or sharing injection drug using equipment with an unknown status partner or a known HIV positive partner. And the other important caveat is that you have to document hepatitis B status. And the reason why that's so important when you use PrEP is because the medications tenofovir and emtricitabine also are effective in treating hepatitis B as well. So if someone was going to start pre-exposure prophylaxis and then stop pre-exposure prophylaxis and they have chronic hepatitis B infection, you may be doing, and we do know that they will be doing, significant harm. The important other points when we do prescribe PrEP, you have to remember that they should only get a 90-day supply and then have HIV testing done every 3 months before you resupply the medication, because if there is a potential that they have acquired HIV, tenofovir and emtricitabine should not be used alone to treat HIV. Also, we need to do side effect counseling when you start someone on any medication in addition to pre-exposure prophylaxis, which includes renal function monitoring. So they should be getting along with their HIV test, a BUN and creatinine every 3 months. Also discuss adherence and the importance of why you should take it every day to prevent HIV. In terms of barriers to PrEP, what we see are very similar to barriers that we see in individuals who are seeking substance use disorder treatment. In particular, there's a huge deal of stigma, negative stigma related to a potential for discussing risk behaviors and requesting help. There's a lack of knowledge, not just on the patient's perspective, but also among caregivers in the substance use treatment programs, as well as in other primary care settings. There's fear. There's substantial fear of requesting pre-exposure prophylaxis and indicating to someone that you may be partaking in high-risk behaviors. And then there's significant other barriers to receiving treatment is similar to what we see in those also accessing treatment for hepatitis C as well as opiate use disorder treatment, including financial considerations, insurance issues, and providers having time constraints and actually discussing all of these interventions and adherence issues as well.
Alan, do you want to talk to us a little bit about HCV prevention?
Okay. First of all, behavioral interventions alone have not been effective at reducing the spread of hepatitis C, so we really need a combination of interventions. People who inject drugs should be provided with clean drug injecting equipment, so not just the needles and syringes, but the cooker, cotton, rinse water, and access to the medications for OUD treatment as part of these widespread comprehensive harm reduction programs. It's important to note that the medication for opioid use disorder reduce hepatitis C and HIV risk behaviors and ongoing transmission. The other concept around treatment as prevention is that we, obviously want to be treating as many hepatitis C infected people who inject drugs, but you need to treat a lot more of the folks if you don't do it in combination with the other interventions. For instance, picking up a thread on Scott County, Indiana, there was a recent modeling study done by Frazier which showed that if you treat at the current level of medication for OUD as well as syringe service program, there you need to treat 25% of all people each year in order to reach the elimination target by 2030. On the other hand, if you're able to scale up access to both the medications for OUD as well as syringe service programs, you'd only have to treat about half as many per year. And we know these medications are expensive and there's a delivery system issue and so forth, so we really want to do this in combination.
So let's go back to the case of Mario, who does have opioid use disorder, but does not have any of the infectious diseases we've been discussing. In Mario's case, he has no psychiatric comorbidity or other medical comorbidity. Buprenorphine, either delivered by his primary care practitioner, if he happens to be waivered, or through a referral to a buprenorphine substance use clinic, is probably the best treatment option for Mario. So let's talk about prevention now for Mario.
And so similarly, his HIV test was negative, and so he was a perfect candidate for pre-exposure prophylaxis, or PrEP, and was offered tenofovir and emtricitabine along with his buprenorphine treatment to prevent acquiring HIV as well, and accepted.
And from the perspective of hepatitis C, certainly Mario may be at risk for hepatitis C, so he should be tested at least annually, maybe more often depending on how he's doing on buprenorphine. And we spoke earlier about the need for combination intervention, so it's great that he's getting his medication for OUD, specifically buprenorphine, but also needs to have access to syringes and sterile equipment, preferably through a syringe service program, but in areas where that's not possible, you can also go to a pharmacy and get syringes and clean needles. This is how we can help prevent hepatitis C in Mario.
So this would be a good example, really, of integrating the treatment of the infectious disease with the treatment of the opioid use disorder.
Absolutely.
Let's talk about another case. Donn is a 58-year-old man who sees a primary care doctor after a change in his health insurance. His new doctor asks Donn many questions about his previous health and social history, including how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons. Further screening and questioning and testing shows that Donn has opioid use disorder and he's HCV positive, but the testing for HIV is negative. So Alan, how would you treat Donn?
This is a very common situation. I think the important thing to note in this new era of oral direct-acting antiviral agents is that we can treat hepatitis C in really any setting, and we should be treating it, whether it's the specialty setting, hepatology, or infectious disease. But more commonly now, we'll see this in a substance use treatment setting, in a buprenorphine program, in a methadone program, in a federally qualified healthcare center, an HIV program. So the guidelines are quite simple now, and what they state is that treatment is recommended for all patients with chronic hepatitis C infection, except those with a short life expectancy, really less than a year, that cannot be remedied by hepatitis C therapy, liver transplantation, or another therapy. So really 95% plus of our patients are eligible. And as I said before, these are all oral combination direct-acting antiviral agents. Medications and durations vary by genotype and whether they have cirrhosis and HIV co-infection, a previous treatment experience. But it's much simpler. There are some pan-genotypic medications out there that are, once daily, either 1 pill a day or 3 pills daily, and cure is high. It's nearly 100%, and that's sustained virological response. So 12 weeks after treatment completion, there's no longer any virus. Again, I urge everyone to refer to the ASLD and IDSA guidelines that are updated regularly, and we'll give you that link at the end. Similar barriers to treatment that we saw for PrEP and for OUD, and we'd like to divide it up by patient, provider, and system. Important to note, though, that we have to move past the barriers. We know how to overcome these barriers. So again, for the patient, it's not being diagnosed, it's the stigma, the lack of knowledge, maybe not realizing that hepatitis C can cause cirrhosis and liver cancer and death, and fear. Providers, a similar thing. There's a lack of knowledge, maybe not getting institutional support, the idea that hepatitis C is shouldn't be in my wheelhouse, I'm doing primary care, time constraints, but that we need to be able to move, change what we believe is within our scope, all of us, to really do the bundled treatments of all the infectious diseases as well as the OUD. And then the system barriers, again, not everyone has insurance, again, fragmented healthcare system, which again points back to the need to have co-located models of care. And also, I think we really need to look at certainly payers need to adhere to evidence-based in terms of who's eligible for treatment, but beyond that, we need to look at alternative financing systems. As with all medications, adherence to treatment can be a barrier, but they're really in hepatitis C, and I'll show you some data, there's no evidence that people who inject drugs have low adherence to hepatitis C treatment, and if they do, that it's associated with decreased outcomes. But regardless, education is important. Pill organizers, case managers, and in some cases, directly observed therapy. I want to talk about one study that we, a randomized controlled trial that we completed out in the Bronx, and this was focused in a methadone maintenance treatment program, but also had some patients on buprenorphine. This was a randomized controlled trial of 3 different models of care to see what are the best ways to treat these patients in terms of outcomes of treatment adherence, treatment completion, cure, or sustained virological response, and we also looked at reinfection. So what we did is we randomized 150 genotype 1 infected patients who were attending the clinic and either receiving methadone or buprenorphine into either just getting the medications on site, and again, treatment was delivered by primary care providers and or physician assistants, or they received the treatment in a group setting, where they would go to a weekly group and receive the medications and get support in terms of support education around hepatitis C. And finally, a directly observed therapy model where they would go to the clinic and you go and get to the window and drink your methadone, but also get your hepatitis C medications. You can see the characteristics were similar between the 3 groups. And if you look at the right-hand column here, the total 3/4 had a history of injection drug use. Nearly all were on methadone. Nearly half had a psychiatric comorbidity. Just about a quarter endorsed drinking alcohol to intoxication. A quarter had cirrhosis, and the majority were on a variety of regimens, but the majority were on combination direct-acting antiviral regimens, 77% of those. And so the results, what we could see is that adherence indeed was higher in the directly observed therapy arm, where 83% adherence in the directly observed therapy arm versus 78% in group and 74% in individual, and that was a significant difference. And we looked at factors associated with poor adherence. There were 2 factors that stuck out. First, of note, any of the drug use factors were not associated. So whether people were using drugs at baseline or during treatment or 6 months before, these are some of the criteria that payers have used to restrict, and providers as well, access to treatment were not associated with poor adherence. But drinking alcohol to intoxication as well as psychiatric illness, there were some significant differences. And then just to show you here, if you look at this cohort, people were using drugs throughout treatment. About half are using a drug, either a stimulant or benzodiazepine or an opioid. The SVR rates were high, so again, similar to other reports, 94% total achieved a cure, and we have 90% in the individual arm, 94% in group, and 98% in directly observed therapy arm. When we looked at the analysis of just patients who received combination DAAs, it was actually 100% cure rates in the DOT. Important caveat, though, there was not a significant difference. I think what's important is that we shouldn't say you have to use DOT or you have to use group. In conclusion, we talked about overall adherence being significantly higher. Treatment completion was very high, so 97% completed treatment, at least 80%. All 3 models of care were effective. When we looked at the week 4 viral load, there was a significant difference in viral load with DOT being better, but over time it didn't hold true. We did note that an increase in adherence was associated with increased cure. So for every 10% increase in adherence, there was a 1.6 greater odds of achieving SVR12. And again, drug use was not associated with poor adherence or cure. And again, the data demonstrates support for treating people who are actively using drugs, receiving medications for opioid use disorder. Everyone gets concerned about reinfections. And so I have a couple points to make about that. Number one is that from a treatment as prevention paradigm, we need to be treating the people that have high-risk behaviors, because if you're treating only the people that aren't continuing to use, or aren't at risk for either reinfection or ongoing transmission, then we're not treating the right people. And in fact, modeling studies will suggest that if you treat enough of those patients, so you get up to 8, 10, or 12% per year, that's where you're going to start to bend the curve and decrease reinfection. So you need to treat a critical mass. But the other caveat is that it's overblown in terms of what, how frequent the reinfections are. And there's a couple meta-analyses that have come out. There was one recently presented at EASL, which kind of broke it down to different cohorts. So people that were maintained on medications for opioid use disorder, there was about a 3.4 or so per 100 person year rate of reinfection. And for those who were recent injectors, it was probably about 5.8 or so per 100 person years.
So just to finish up with Donn, Alan, what would your treatment recommendations be?
Yeah, absolutely. So I think there's a number of different medications that can be used that are simple. And I again would urge our viewers to take a look at the ASLD IDSA site and also learn how to treat. If you don't know how to treat, there's different ways to do it. I think the Project Echo or similar telementoring-like models learn through, joining a weekly seminar, shadow a provider. We're going to show some resources where you can call a national, kind of consultation line to learn how to treat. That would be the preferred method, but otherwise, really use warm handoffs if you want to refer it off-site. And there's some emerging evidence around care coordinators or peer navigators using contingency managements or providing modest incentives so people can show up to the next point. But inevitably, you're going to lose patients if you have to refer off-site.
And again, for his opioid use disorder, some medication treatment would certainly be.
Absolutely. I would say that ideally, you could treat both the opioid use disorder and the hepatitis C in the same setting.
I'd like to move on now to a third case presentation. Amanda is a 33-year-old woman with opioid use disorder, and she's been in several treatment facilities over the past 5 years. Currently, she's using injection drugs. After she visited a walk-in clinic for an infection in her arm, she was screened for both HIV and HCV. At this point, we know that Amanda is positive for opioid use disorder, HIV, but she is HCV negative. So Sandy, you want to talk a little bit about the treatment of HIV in people with opioid use disorders?
Sure. This particular case of Amanda illustrates other important points that we're seeing across the country. Is not only are we seeing HIV and hepatitis C increasing in people who are using drugs, but also other bacterial as well as fungal infections that are really probably the red herring before HIV and hepatitis C actually develop, which include these skin and soft tissue infections, which I believe Amanda is showing up in a walk-in clinic here for probably an abscess from injecting in her arm. So unfortunately, Amanda has acquired HIV probably through either sharing injection drug use works or a combination of both, of having unprotected sexual intercourse in the setting of drug use or exchange sex for drugs. Treatment is, as Alan was talking about earlier, has become very easy for HIV now. The guidelines do indicate that we should be treating all individuals living with HIV with effective antiretroviral therapy. And I will go into the reasons for that, but many of you may have heard of the U=U campaign. Have you heard of that? We want to get individuals to be undetectable from a public health standpoint, because there's definitive evidence now that if you can keep a patient's viral load to undetectable levels, they cannot transmit HIV to an uninfected patient, even in partaking in high-risk behaviors like unprotected sex or sharing injection drug use equipment. This is a slide taken from the NIH AIDS info guidelines, which talks about which medications are effective. And I'm not going to go into all these details, but there's many antiretroviral therapy regimens that are effective in treating HIV. And there are very simple one pill once a days that have 3 medications in them that patients can take that are easy to take. So the goals of treatment, as I had mentioned before, are from a public health standpoint. The U=U mean we're less likely to transmit HIV to an uninfected patient if you can maintain their viral load to suppressed levels. But the other goals are obviously to reduce mortality and morbidity in a patient living with HIV and improve their quality of life.
Sandy, remarks about the abscess kind of stood out, as well as the fact that this is a patient with opioid use disorder. And oftentimes we get patients that come in and providers will be focused on just what we know best, right? So HIV will resonate, or Hep C, I like to treat Hep C, or if you're addiction medicine. And so I think part of the catch here is that this is an opportunity to really check in and see, are you in treatment for your OUD? If not, you can start and initiate treatment for that as emergently as we want to start treatment for HIV. there's a sense that let's stabilize one condition before we move on to the next, and that's really not how my practice is. In some cases, you can't do everything because of time at the same visit, but you can touch on each of the aspects and start to bring people in. It also helps with retention, because what I've found is that if you're engaging with the Hep C treatment, that might be the hook for someone. Maybe they're a little ambivalent about their drug use. They see that their Hep C viral load is decreased, and so forth. So same thing with this, the HIV viral load, it starts to decrease. Maybe they're interested in that, and all of a sudden they're ready to look, more intently on their addiction.
And I think the critical part here is that the treatment of the opiate use disorder is helping to treat the HIV through maintaining viral suppression, as well as, from a preventative standpoint, decreasing likelihood of her, if she does partake in high-risk behaviors, transmitting HIV. So I think that's critical.
Great. Well, why don't we move on to case number 4. Brian is a 35-year-old male with opioid use disorder who has been on medications for opioid use disorder. Screening upon entry to a new treatment program shows that he has both HIV and HCV infections. So Brian is positive for opioid use disorder, positive for HIV, and positive for HCV. Sandy, what are your thoughts?
Yeah, so unfortunately, this is a common situation that I see. We usually see a high level of comorbidity of all of these diseases. With that being said, this again showing some statistics that although overall 20 to 30% of individuals with HIV also have hepatitis C, but among those who are living with HIV and injection drug use, it's estimated that 75 to 90% are co-infected with hepatitis C. People with HIV and hepatitis C are more likely to advance to cirrhosis and end-stage liver disease, and in a very shorter period of time than those who are mono-infected, and also more likely to advance to hepatocellular carcinoma. All patients with HIV, therefore, should be screened for hepatitis C, and also, if positive, she should initiate integrated treatment. It's also important to note that most of the medications for hepatitis C now are much easier to take than the olden days, which when I started out with pegylated interferon and ribavirin, and tend to interact less with the antiretroviral therapy for HIV. Would you agree, Alan?
Absolutely. I do. I think it's important there's resources which we'll show at the end, the Liverpool site, to look at the drug-drug interactions, but there's usually, you can get through it, or you can make a change, and either if you do both HIV and Hep C care, you can do that yourself, or you can work together with your colleague to make a change. There is a belief, I think, for some HIV providers that HIV is the most important illness, and adding another pill or pills for hepatitis C might compromise treatment for HIV, but that hasn't been shown in the studies. In fact, we looked in our PREVAIL cohort that adherence was actually higher in those who had HIV or equivalent, to those that were Hep C mono-infected. And in fact, people have already confronted, a chronic disease, that's really lifelong treatment, and so are very good in terms of adherence.
What I would say for this particular patient is that we can initiate HIV treatment, and then I don't necessarily start both the Hep C and the HIV treatment at the same time.
I agree with that.
But I start out with the HIV, and then I'll make sure that they're coming back pretty quickly, maybe every week in the beginning, just to see how they're doing, and then initiate hepatitis C treatment and talk about the cure for hepatitis C.
I do the same. I mean, usually whether a month or a couple months, just to make sure and look at the adherence issues. Yeah, sometimes there's exceptions to the rule if someone really is reluctant, and we've used Hep C as a hook, but in general, that's the sequence that we use.
And then also treating their opiate use disorder all at the same time. That I don't postpone, I do. Right
of course,
away, right?
Yeah. And the data supports it's better for your HIV control as well.
So for HIV treatment, peer navigators are considered an evidence-based intervention that have been found very effective, and after testing positive for HIV, linking them to a provider in the community. But when we get to referring, I think we have to be really careful and understand when you send a patient to another provider, trying to decrease the barriers to getting to that provider is really important, and so understanding and making sure that everybody's on the same page. So I guess reasons for why I might refer is if potentially there's increased severe psychiatric illness, suicidal ideation, comorbid major depression, maybe other delusional behavior that I need support from psychiatrists. For hepatitis C, for me, would be referring if they have cirrhosis in addition to maybe a risk for hepatocellular carcinoma, or might or have hepatocellular carcinoma, and then we have to talk about liver transplantation.
Yeah, I think the confidence is the key thing. I mean, you know, the providers through training and what they've learned will feel comfortable or not. And if you're not comfortable, then you should always, you know, refer. Unfortunately, we don't always have places to refer, and so that's and that then kind of doubles down on your resolve to want to learn how to do these things.
And I think even when you feel the need to make a referral, you can hold to the principles of integrated care by keeping a close connection with the referral source. So even though you've referred someone who has multiple psychiatric or other complexities, that doesn't mean their HIV doesn't still need to be treated. So I think that's where we need to really bridge these gaps between different types of providers when we can't have them all integrated in one site, which is clearly what we think is optimal. We need to make sure we stay closely connected even when we refer a patient. In the old days, in substance abuse treatment, they actually used to discharge people from treatment for using, which is so counterintuitive because exactly the reason they're in treatment is because they have lack of control over their use. So I think we really are developing a more nuanced approach and really meeting patients where they are in terms of their readiness to change. And I think if what you can engage them in is treatment for HCV, that's where you need to engage them. The last thing we need to do is discharge them for treatment for doing the exact behavior that's causing them and society so much harm.
Yeah, that's perfect. Another thing that we're doing is with our local substance use treatment program, we actually have a counselor working at our office-based model, and so that's part of too when they're building that trust, and so we want to work together so that they can see that, oh, if I need intensive outpatient program, I already have that counselor here, and he can start to bridge, you know, that gap. So we just want our patients to see that we're all working together, you know, for their common good and their health. And I think all those things, you know, by being more flexible and patient-centered and using motivational interviewing, we really can overcome some of these barriers.
Now we're going to move into the Q&A portion of the program, so please send us your questions.
Thank you, Drs. Brady, Litwin, and Springer for today's presentation. We will now switch to the question and answer section. Due to time constraints, we may not be able to answer all of your questions, but we'll do our best to address as many of them as possible. All right, doctors, take it away.
Okay, hi, this is Dr. Kathleen Brady, and I have one question here from an attendee that I'd like to address to actually both Dr. Springer and Litwin, and I think it's a very practical question. This is, are there any studies on how to best integrate this into practice? And I'm assuming they're talking about really treatment and screening for HIV, HCV, and opioid use disorder. And then they just ask things about how long are these appointments? Is there more success if you make it separate clinic days versus scheduling it along with all of your other patients? So I'd love to hear from you two. How do you handle these complex patients in your usual routine practice?
So this is Sandy Springer. Thank you, Kathleen. And so I guess to tease it out a little bit, so for HIV testing, we recommend HIV testing, and as we said in the webinar, for those at risk, and at least, you know, one time in that one cohort that we discussed, but more frequently if you're partaking in high-risk behaviors and hepatitis C. Also testing now, recommendations are ages 18 to 79 one time, but if you're partaking in high-risk behaviors. And then opiate use disorder, we would recommend screening in all persons as well. In terms of pre-exposure prophylaxis, you know, in terms of what the study, if there's studies that have looked at what the best practices are, they're more practical questions, but you know, for me, I do pre-exposure prophylaxis screening, so asking about risk behaviors, and all of my patients that I see, they're just incorporated with routine questions that you would ask among any individual. They don't take very long. You can, however, have a separate pre-exposure prophylaxis PrEP clinic visits if you'd like, and similarly for hepatitis C as well, and opiate use disorder. But one of the things we really are trying to advocate for is that they should be incorporated, integrated along with all together, because individuals who may be partaking in injection drug use or other drug use, or partaking in high-risk behaviors, it's a great opportunity to kind of incorporate all of our screening questions and testing together, especially for opiate use disorder, and linking, if necessarily, buprenorphine treatment or other treatments. There are two schools of thought, though, that one, refer out to a specialist, or the other thought would be to integrate and incorporate that with your general practice, whatever it may be, substance use or primary care or specialty care.
Sandy, do you have any comments on the new the United States PS Task Force HCV screening recommendations?
Yeah, I think that the biggest thing is they've now recommended it for universal testing for all individuals 18 to 79. So not just the baby boomer, a birth cohort of 1945 to 1968 anymore. And that, which is really important, because unfortunately, as we were discussing in the webinar, that we're seeing more new infections, hepatitis C infections, as well as, unfortunately, HIV infections occurring among this younger group. We also know that DAA treatment, directly acting antiretroviral treatments for hepatitis C, are safe and highly effective in that cohort as well, in the 18 and older group, leading to sustained viral response, cure, and less liver morbidity and mortality. So I think the guidelines to recommend hepatitis C antibody screening in that particular group, that typically includes more individuals who may have been injecting drugs or using drugs, as well as young women that are routinely not being screened, is really important. And I think that is the bottom line, that there's now, the guidelines have now come out to recommend that, which is, I think, is really important. And that could then link to effective medication, curative medication treatment.
There's a couple of questions here that I think are interesting. They sort of circle around the same thing. It's basically any tips for overcoming insurance barriers for prescribing either PrEP or the new HCV medications?
Yeah, so that's a tough one, because I'm in a Medicaid expansion state. So those all the medications are covered for opiate use disorder, hepatitis C treatment, as well as PrEP. For PrEP, now that tenofovir and emtricitabine, known as Truvada, has now become off-label, it's much less expensive now, which is important. And so in terms of insurance barriers, I think most states are now individually wise recommending treatment regardless of the stage of liver fibrosis. So I think that's also important. And I think it is unfortunately true that you sometimes have to call the insurance company and act on the patients, the best advocate for them for these treatments. It's with Medicaid expansion, we are seeing reduced morbidity from these underlying diseases. But I do agree this is a challenge for many individuals who are living in non-Medicaid expansion states to overcome. And it's really, if you can have an additional person that can help talk to the insurance companies and advocate for them, that is can be helpful.
Yeah, I agree. And Cindy, I come from a non-expansion state,
right?
And so one of the things that we do, if we have an ECHO or sort of a telemetry network that deals with this patient population in particular. And one of the things that is, I think you're right. Sometimes you just have to call, or someone in your office has to call. But what I would encourage people to do is, if you are having a hard time, talk to other practitioners in your area and find out what's been successful. You're going to find somebody who's been successful, sort of pick their brain about because what we've ended up doing is sort of sharing templates across the state for addressing this, because there's nothing more frustrating than actually taking the time, to make that call and get someone on the phone and then have them not accept your rationale.
Right. Right.
So it's good to share success stories in that way.
Exactly.
We can really learn from each other a great deal.
I agree.
One other question. What do you think about the new drug for PrEP, and how is it different from the original?
Yeah, so the medication they're referring to is, it's brand name Descovy or TAF and tenofovir, adolphenamide and emtricitabine combination tablet. It was recently FDA approved for pre-exposure prophylaxis. It is the former medication Truvada, tenofovir, emtricitabine, what became generic, as I had just recently mentioned, in 2020. So this one is not, and is more costly. I think the important things about the newer medication is it has not been studied among cisgender women or people who inject drugs. It's only been evaluated in men who are having sex with men and trans women, versus the former medication has been evaluated and found to be effective in all of the other populations. So the question is does the cost outweigh? Is it any better? I mean, I think the evidence, we need some more time. There are some small caveats in that potentially the newer medication may be less harmful, or if you want to say harmful, in those with poor renal function. And there might be a slight increase in LDL and weight gain in the newer formulation compared to the tenofovir and emtricitabine medication. So I think the jury is out right now, and I think the most important thing, as I just mentioned, was we do not have any evidence, or there have not been any studies of the newer medication TAF and emtricitabine combination tablet in heterosexual cis women or people who inject drugs yet.
That's an important thing for everyone to note. One last question, Sandy. Any interactions between medication for opioid use disorder and PrEP that the practicing clinician needs to know about?
No, right now they all look pretty safe.
Yeah,
no interactions that we know of really with buprenorphine or methadone or extended release naltrexone that are notable as far as we're aware yet. So that's good news.
Yeah, that is good news.
And I think the other important point is, unfortunately, we're not seeing people who inject drugs or use drugs being offered pre-exposure prophylaxis. And I think
I know that really is. And I wonder what we can do to impact that. I think, webinars like this are helpful, but we need to get the word out.
Yeah, and I think it's education providers, it's educating patients, and thinking about where patients do go to receive their care, in particular for women who are even less likely to receive or be offered PrEP. OBGYNs, Planned Parenthood, other populations also have to be aware of substance use disorder treatments. But it's important to discuss and just remind that drug use as well as condomless sexual intercourse are increased risk behaviors, and it's for HIV, and that they can prevent HIV through this medication.
Claudia writes, as a primary care provider, do I need specialty registration to treat HCV patients?
No, you don't need any special. I don't know if there's any, or if they're a primary care. I know that some states, I did speak with somebody in Kentucky. So there are certain clinicians, non-MD clinicians, that have to require certain training, I guess, but at state level. I don't want to speak more to that. That's just what I heard through talking to one particular clinician. But in general, you don't need any special training to offer hepatitis C screening and then knowing, what to do and offering direct antiretroviral treatment, DAA treatment. They are so easy to use and very few side effects, and basically in 8 to 12 weeks, curing hepatitis C. So if you can offer it, I would highly recommend it, because you can actually cure, one of our deadliest diseases, infectious diseases in this country. And just be aware that to reduce reinfection, to continue to offer, support for their underlying potential substance use disorder, medication treatment, and syringe service programs as well, if you can link them to those.
Are there any interactions between MOUD, or medication for opioid use disorder, and PrEP that prescribers and clinicians should know about?
This is Sandy Springer. Right now, so PrEP, which is Truvada, or tenofovir emtricitabine combination medication, and now as of this webinar, Descovy, which is the TAF formulation, and emtricitabine. There aren't really any significant interactions with buprenorphine or or extended release naltrexone or methadone for the most part. Now with those two meds, there may be some particular things that you might want to monitor, like we always monitor renal function, but not specifically related to buprenorphine or methadone. So they're pretty safe and not terribly onerous to monitor. The only key thing about PrEP, of course, is you have to ensure that you're retesting for HIV every 3 months. So those are the big issues, and just on their own measuring their kidney function, the BUN and creatinine every 3 months as well, but not necessarily because of related to buprenorphine or Vivitrol.
Great, thank you for that, Dr. Springer. Dr. Brady, anything you wanted to contribute from the OUD side, or?
No, I think I would agree with that the combination is, there's really not much to worry about in terms of this combination.
Great, well, thank you for that. Our next question that we have from today's learners are, any tips for overcoming possible insurance barriers to DAA prescribing?
Yeah, so this is Sandy Springer. So in terms of what are the strategies to overcome insurance barriers, it is a major problem, and especially if you're in a non-Medicaid expansion state, or even in a Medicaid expansion state where there might be particular rules or guidelines. As far as I know, many of those states though have changed their guidelines. It used to be you had to have a severe fibrosis score in order to access treatment if you're on Medicaid, but those seem to be overturning as far as I know. I don't have any special tips on how to overcome insurance barriers. I understand this is a major frustration, and it shouldn't be, because from a public health standpoint, we should be able to have access to these life-saving medications that actually cure hepatitis C. So I don't have any specific response.
Yeah, this is Kathleen. I'd have to agree with you. What number one is that, and I'm in a Medicaid non-expansion state, so I would say that it's becoming easier. I mean, that some of the guidelines and have liberalized, and we have less problems with private insurance than we used to. The only other thing I'd say is that in general, in terms of overcoming insurance barriers, I mean, I think one of the main things, and I know it's hard because physicians are so pressed for time, but I think that the main thing is you have to challenge a denial. And I can't tell you how many times in just challenging a denial, it's like that's not what they expect. And sometimes just the act of doing that and getting another physician on the phone and talking to them with patient details, I've been surprised how often that works.
Yeah, I agree with you, Kathleen, but you do, unfortunately, it's time consuming. But
it is. It's very time consuming, but it's probably the single thing you can do that would be most effective?
Maybe having someone in your team who could help.
Absolutely.
That's an issue, and doing it ahead of time, I think, instead of,
True.
pile up. But it is really difficult.
Thank you very much, both to you, Dr. Brady, and to you, Dr. Springer, for taking the time today and for today's presentation. We really appreciate it.
I just want to thank Dr. Springer for attending and giving such great answers to all those questions, and really thank all of you in the audience for your attention and your interest. It's been a very illuminating hour that we spent together. Thank you.
Here you'll see a few of the important updates and reference slides and resources that were referenced throughout today's webinar.
It's time for us to close the program now. And I'd also like to thank our speakers. Thank you, Dr. Springer. Really wonderful presentation.
Thank you. It was really nice to be here.
And Alan, thank you for your presentation, and both of you for the discussion.
Great, thank you both, I enjoyed it.
And I'd like to thank all of the viewers for joining us and for your participation.